So I want to discuss a bit about the actual service, because if you can refer into the service, then obviously we will get better education for children with asthma and wheeze. I'll go through the referral criteria, what templates we're using. At the moment we're currently developing them more, but once we've got them finalised, then you will be able to access them to use when you're doing your annual reviews and seeing your children with wheeze and asthma. Also looking at management plans, weaning plan, what to do at the 48-hour review, and also looking at some community guidelines that might help you. And I've just got some scenarios at the end for you to have a look at and see what management you might give for those children. So this basically is the clinic that I have. I would go to 8 different GP surgeries on a 2-weekly rota. These surgeries were chosen because they showed an interest and also because they have clinic space. So it's basically looking at children with high risk of future exacerbation, so we're trying to prevent that. And it's all based on NRAD with the criteria of patients that we're seeing. So this here looks at the referral criteria, so anyone that's had an admission within the last 12 months. Currently I'm looking at admission data from Bart's Health to see who's been admitted, and then I'm referring them to myself and giving them a clinic appointment to come back for a review. Anyone that's ever had a PCU HDU admission, because they obviously have had a severe acute episode, that they're more at risk. If they've had more than 2 exacerbations of wheeze in the last 12 months, and that can be A&E out of hours, seen by you twice, then they can also be referred. If they're using more than 2 blue inhalers a week or 10 a month, difficult sometimes in children because they have one at school, they have one at after school club, they have one at Nan's, they have one at Dad's. So sometimes it's difficult to tease some of that information out. If they're not collecting their repeat prescription for their steroid inhaler, also is important to pick those up, and that's obviously why they're having increased salbutamol overuse. Those that have poorly controlled, so if their ACT is less than 19, then their symptoms aren't controlled and they can also be referred into the clinic. Anyone that's on BTS step 4 and above, and if there's parental or professional concerns about compliance. So when I see them in clinic, I tend to do a one-off clinic consultation and not need to see them again. But if it's a compliance issue, then I sometimes ask them to come back, because I think it's important to keep reviewing just to make sure they're maintaining that compliance. So basically we want to reduce admissions. We also want to make sure that young children are seen within 1 month of discharge within a specialist follow-up, whether that's in hospital, whether they're seen by me in clinic. It doesn't have to always be in secondary care. It's with someone that's got an interest and specialist within that area. Making sure that we look at their inhaler technique, making sure that they receive a personal asthma plan, they have their symptom control tests looked at, improving information sharing. Also looking at improving attendance with school. I'm doing lots of work with schools to try and make Tower Hamlets asthma-friendly schools. It's also them being able to refer into the service as well, the school nurses. Making sure that I can give my knowledge to you guys to actually help and improve when you're doing your consultation within paediatrics. So I don't see children at 48-hour or the 72-hour review because my clinics are too spaced apart for me to be able to fit in that. So I always say to patients, if they've been unwell and they've started their salbutamol, they need to have a review with the GP, and I explain to them why it's important for the 48-hour, and I'll talk to you a little bit about that in a minute. Obviously, routine asthma reviews, if they've got a high risk and they're part of the criteria, then yes, my consultation can be classed as part of their annual review. Currently at the moment I'm recording on EMIS Community, and I'm hoping on a monthly basis I can let the surgeries know that I've actually seen them. So if you want to use that as part of their annual review, then you can do that, but that's work in progress at the moment. And obviously, yeah, I've done that one. So this is how we refer. You can refer via EMIS. and you go through your normal referral pathway, and you fill out the Specialist Children's Health Service referral for Tower Hamlets, and that's the same form that you fill out for the Community Children's Nursing Team, or any other community paediatric services. It's a new form that's out now. There's a box that says asthma, and if you just say why you're referring and if it's urgent or not, just that I know why I'm booking them into clinic, and then I'll book them into the next available clinic that I can do. Also, there's my details there if you wanted to ring or email for any advice, then you can do that as well. So the clinic actually is a 30-minute consultation, so longer than yours. I'm finding that I might need longer than 30 minutes sometimes, because some families obviously want to talk quite a lot, and then we end up talking about exercise, we end up talking about diet and allergies, so sometimes some of them can be quite lengthy, which obviously is hard for you to do if you're seeing them for 10 minutes. So we've got an EMIS template, which is all structures, and I'm working on to try and smooth that out to be able to let you be able to use that as well. Reviewing their diagnosis, looking at what steps they are. Is it actually asthma? Do they have any other conditions that are contributing? Normally children, when their symptoms aren't controlled, it's for something else, because they're taking inhaled steroids. It may be that they have signs of reflux or uncontrolled rhinitis. We've had a few children that have been managed with asthma and they've turned out to have bronchiectasis. So it's basically starting from scratch and finding out the cause of what's causing them to have the exacerbations. So that's also looking at history, how many admissions they've had, how many times they've been to A&E, looking at their school attendance. Making sure that they actually know what their triggers are. A lot of them don't associate their triggers with what's actually happening with their wheeze. So I do a lot of work with triggers, and we'll give them advice if it's hay fever season, take your antihistamines, rhinitis, making sure that they're taking the nasal spray properly, and they're taking it regularly. And I have had some children that are living in quite poor, damp, mouldy situations and having to help support with housing letters for that. If they've got rodent infestation, I had one asthmatic before where was being admitted several times to hospital with continual wheeze, and she was having pred every single month, and it turned out that after skin prick testing we found out that she had a mice allergy and the house was infested, and then we had to get her rehoused, which changed her whole situation and improved her asthma, her quality of life, and her symptoms. So triggers do play a big part on that. I think we need to make sure that we bear that in mind. Also listening to their chest, have they got any chest deformities, looking for clubbing, those sorts of things, so I'll do that within my consultation. So review the ACT, we've got within my template, we've got My Asthma Project, which has got how to use inhalers, it's got ACT, and it's got lots of useful resources. So I'm checking how their symptoms are, and this is a good tool to find out if they're having issues with compliance. You might change treatments. Your ACT may be only 8. You're making sure they're taking their steroid inhaler. They'll come back to clinic within a month's time, and then you can find that they're actually, the ACT is maybe up to 24. And I find that most children, if there's a number and they can see an improvement, it helps them to actually understand, the same as the peak flow, to know that there's an improvement in their peak flow. Making sure that go through inhaler technique. Within paediatrics and young people, we always use spacers, and the reason for that is because we get correct delivery. If you have smaller children, then they can use spacers with face masks, but anyone over the age of 5 needs to be having a mouthpiece, and I'm finding a lot of children that are older have actually got face masks, and obviously they're not getting correct delivery, so we need to make sure that we're giving the correct spacer around that as well. I have found a few children with accuhalers. We tend not to like using accuhalers in children, young people, because it's very difficult to inhale, especially with exacerbations. And some of the investigations with NMAD has found that some of the children that had died was because they were actually put onto an accuhaler instead of a spacer. So we always say, always need to use a spacer. There are some children that if they're going to do PE, don't want to get their spacer out, so I may use an easy breathe for PE only, but then they always have their spacer and their salbutamol for exacerbations. I find that they don't always remember or take it in, so sometimes I'm repeating the same thing time and time again until eventually they do get it. So each time it is repeating the same thing, but I tend to say, tell me what I taught you last time, so I see what they remember and then I fill in the gaps. We've got a leaflet here which we're using Bart's Health and across North East Asthma Working Group. And that's got all the information you ever know. So if you forget everything I've said today, then that leaflet is really good so that you can actually use that to teach the families.
Sorry, where do we find that leaflet?
If you want the leaflet, it's in my asthma project, but when I've got the template built on EMIS, I'm going to get it built within so that you could just press it and print it from clinic. If anyone wants them separately, they can let me know and I'll email it to you. It's not a problem. And then also making sure they have a management plan, which brings me so we're using the same as what they are in adults. They're the adult template as well from Asthma UK. You've got the 6 to 11, which is the one above that, and then you've got the Preschool Wheeze one here. We're using this across Bart's Health. Community nursing teams using it as well as the school nursing team in Tower Hamlets. And across NELFT is also approved to use it. So we're trying to stick to the same ones because it's easier for everyone to understand, it's less confusing for children and family. One of the things that I'm finding is that people give a management plan, but don't actually tell them what to do with it or actually how to understand it. So I'm going to go through a little bit of how to do that. Obviously it's time consuming, so I'm getting them built within EMIS. So it'll be pre-populated and those sections at the top left, that's all you have to fill out, and their name and everything will come up, and it's as a document, so you can just print it and you can save it and you can potentially amend it for when you come to see them next time. So hopefully I will work out how I can share that with you guys so that you can use that, and that is for all 3 of the management plans, just to make it easier. So when we look at management plans, there's 4 basic steps with any of the management plans. The first step is what's their normal medication. Step 2 is when they start to become unwell. Now, most children and young people, their trigger is a cold. So I always say to them when they have a cough or a runny nose, whatever comes first, start their salbutamol. And that's to open the airways and prevent them from having exacerbations. And that often does the trick, and then they don't need to come to hospital. With the smaller children, if they use under 5, if they're using 5 puffs every 4 hours, I say to them, please go and get your GP review at that point so that they can be listened to, so you can decide whether it's okay for them to go up to 10 puffs or whether you feel they need to have some steroids tablets started, a rescue course started. If you get to step 3, then they're using 10 puffs every 4 hours, so they need to have that review. I always tell them, please try and make sure you get an appointment with the GP earlier, act earlier on in the day. As it becomes to night time, they go to sleep, they're unwell, then they get a rush to emergency. So I always tell the families that if they're using 10 puffs every 4 hours and they're not getting better, that's when they need to be getting their rescue pred. Now I know that sometimes in the smaller children it's should we be giving steroids or shouldn't we be giving steroids when they're unwell? So I tend to say if there's a family history, if they've had them before and they've worked, and they're that sick, then it's worth actually giving a trial to see if it actually helps with them. Step 4 is an emergency. So often you'll do your 10 puffs every 4 hours, but after 2 hours they'll be wheezy again and they'll be struggling to breathe. So they can do a burst therapy, like what you do in A&E, but we're saying they can do a one-off at home. They can't carry on doing it because obviously that's unsafe. So they give 10 puffs of their blue inhaler, wait 10-15 minutes. If they're no better, then they can repeat it and call an ambulance. If they get better, they can then go back to 4 hourly. If they can't stretch to 4 hourly, they need to be coming to A&E. Yeah. Now, obviously, if you've got a child that's got allergies and a lot of the children that we've had that have died within Tower Hamlets turned out to have anaphylaxis, and we're finding a lot of asthmatics with allergies aren't necessarily physically showing signs of anaphylaxis with facial swelling, but they're having anaphylaxis in their airways that no one can see. So if they have an EpiPen and they've tried their burst therapy of salbutamol and they haven't made any improvement, then they should be given the EpiPen. And this is a poster that we've designed with schools, because one of the children that died at school actually had an anaphylaxis, and that's why we've developed that. So I'm always making sure in clinic I show them how to use the EpiPen, and I say to them if they have an asthma attack and they're not getting better, they need to use their EpiPen. Yeah. So we also wanted to try and standardise Weaning Plan to make sure that people aren't getting confused. So this is a Weaning Plan that we're using, which is also in the leaflet, which is 10 puffs every 4 hours. So we keep them on the 10 puffs and we actually wean the hours, and that is because then we're giving them more salbutamol, so that we're keeping the airways open, we're preventing them from having a hospital admission. Now, obviously, when they're following this, it's by day, but some of them might not start until the evening. So I say to the families, make an assessment. If things are getting better, then start weaning. But some of them may need to have 2 days of having the 10 puffs every 4 hours. Some families will do this regime and not need oral steroids. They're able to wean it themselves. So when you're seeing patients for a review, it's important to ask them how much they're given and how often. No one should be doing it hourly or 2 hourly. Yeah?
Is it 10 puffs in a volumatic?
Yes, we always use the volumatic.
And 2 breaths?
So we do one squirt and then 10 breaths. Take it out and shake it, another squirt and then 10 breaths. It's 5 to 10 breaths. I like 10 because if you're having an asthma attack and you're hyperventilating, you're going to need that volume to help calm and concentrate your breathing. So I always use 10. But you would never do this in your mouth because they're going to be so wheezy. It has to be with a spacer. That's why we say all children and young people need to have a spacer. Yeah. So these are the things that you might be looking for in your 48 to 72 hour review. Obviously it's difficult if someone's discharged at the weekend because you're obviously not there at the weekend services as best as we can. And the reason that we say that is that we're actually checking to see if they're improved. NRAD, when they looked at people that died, it was because they never got a repeat review. So it's important that we make sure that they get that review, and we are trying to work on the CRS template that's sent to you, and hopefully we eventually will get the management plan and we'll get a section that says please do a 48-hour review, check this, so it makes it more clearer when they're discharged to yourselves. Checking their peak flow. Obviously some children's peak flow is not very good and is not always very reliable. So in hospital we are trying to do them, and in clinic I do them, but sometimes they're not always very accurate to be able to use. So it also is important that you look at your ACT and you look at the symptoms and having a listen to them and seeing if they are actually improving. One of the things is looking at the review of the salbutamol weaning. Is it fine for them to continue weaning, or are they still wheezy when you're seeing them? Do they need to have a longer course of prednisolone? The standard is for 3 days. When you see them in a 48-hour review, if they're still wheezy, they're still needing 10 puffs every 4 hours, and that means that they need to have a 5-day course, so that you can just then start the weaning once they're starting to feel better. Why did they actually have this exacerbation? Was it because of a cold? Was it because of compliance? And it's about re-educating and looking, do they know how to use their management plan? They also do suggest about reviewing within 1 month of exacerbation. And that's really just to make sure things are continuing. We're having a lot of children that are being admitted month after month after month. So if you're reviewing them at 48-hour and you're reviewing them after a month, then you're actually trying to prevent them from going in again and looking at why they're presenting. Now we all know the BTS asthma guidelines. I'm not going to go through all of those. It is quite... Dr. Nicoro's come up with a community-based version which combines that to make it a bit easier for you so that you know what treatments to do and what to do. So basically, if you've got someone who has nocturnal cough, having lots of exacerbations with cough, wheeze, they're having exercise symptoms, then and they're using their blue inhaler more than 3 times a week, then you would and they've got low ACT, you would then actually introduce a Clenil inhaler. So this applies to the children that are under 5 that are having preschool wheeze. So when we say preschool wheeze, we treat a preschool wheezer, actually a preschool wheezer is triggered by a wheeze. An asthmatic can be triggered by, did I say that right?
You know.
No. A preschool wheezer is triggered by colds. An asthmatic is triggered by colds. So it's both the same treatment. We both treat them with salbutamol. So instead of getting caught up with you've got asthma, you haven't got asthma, you're too young, it's the same treatment. So it's important, if you've had a child that's been admitted several times that maybe is 3, there's no family history, we know that every time they get a cold, their airways are inflamed, they're having exacerbations, they're coming to hospital, they're needing steroids. So those are the children at a greater risk. Having a Clenil inhaler that calms down the inflammation, prevents that episode, that attack, that pred, that's more beneficial for that child and family at putting them at risk of keep having hospital admissions. It may be as they grow up, they grow out of it, or it may be they start to develop allergies and symptoms like that. So we're trying to not keep it divided, it's the same thing, yeah? Inhaler, and the doses do obviously depending on the child. If their symptoms are still persisting, they still have low ACTs, then we would add on a Montelukast. If their symptoms are still persisting and they're not progressing, then that's when you might consider being referred to secondary care. And that's purely because there is the abilities to do skin prick tests, lung function, finding out why their symptoms aren't being improved. Because asthmatics should be improving when they're having inhaled steroids, and if they're not, why are they not? We need to look at why that's not happening. Most of the time it's education and compliance, and by doing that you can sort out and not need a referral. So that's why it's important to do all of that stuff first, yeah? This is what we all want. This is what should be happening for wheeze and asthmatics. So it's important that when we're reviewing, we're looking, this is the ideal. And if we haven't got that, why haven't we got it? So it's readdressing and re-looking and actually thinking, why have we not got that?